pleasure to introduce you to today's CRISP workshop. For those of you that haven't been here before or have forgotten, this year's series of workshops and talks focuses on PCORI funding and different aspects of patient-centered research. Each workshop in the series focuses on a different aspect of patient-centered outcomes research, including the one today, and a reminder that recordings of prior sessions are available on the CRISP website. It's my pleasure to introduce today's speaker, my friend and colleague, Dr. Borsika Rabin, who's one of the rising stars of dissemination and implementation research. As many of you know, Borsika worked with us here at CRISP on Accords, and is still working with us on a couple of projects, I'm glad to say. But this past year, she moved to San Diego, where she's an assistant professor in the Department of Family Medicine and Public Health. Borsika has broad research interest in the field of dissemination and implementation, especially focused on communication and coordination. And she has a special interest in cancer survivorship related issues and in the evaluation and development of interactive web-based interventions and tools. As part of this research, Borsika's developed and designed a number of web-based resources, including the Making Research Matter web tool and the Cancer Prognostic Resources website. I encourage you to take a look at those. And without any further ado, let me turn it over to Borsika, who's going to be speaking with us today, as you can see, on fidelity and adaptation and implementation science. Thank you so much.
Thank you. Well, good afternoon, everyone. It's really fun to be back here and a pleasure and honor. I am going to talk about a topic today that is not in the portfolio of my big, highly researched areas, but an area that I am trying to get into actually and understand more about. And I think the field is somewhere in an early stage as well. So what I will be presenting today will be not necessarily work that I am doing on a daily basis, but what I am trying to do for the future years, and then also just the literature, where the literature is in this area, what kind of tools we have at hand to document fidelity and adaptations and to conceptualize it, and also talk about future research questions. I am also hopeful that you all have some work in this area in one way or another, whether it's a systematic way of approaching this or somehow tracking it in your own work. And please feel free to stop me as I am talking if you have related experience and share it. We will also have opportunity at the end with a Q&A session to talk a little bit more about specific projects. So I will do a few different things. First of all, I would like to provide some definitions just to have common shared language for us today. I will also talk about how we can address the tension between fidelity and adaptation and share some different methods that have been developed by other colleagues from different fields. I wanted to summarize some of the major models and instruments that are out there that you could use in your own work. And finally, just to start a discussion about future directions for fidelity and adaptation. So in terms of the definitions, when we think about fidelity, we usually think about the degree of fit between a developer-defined components of an intervention and how well those are actually being implemented in a given setting. In this context, we often differentiate core elements, the active ingredients of an intervention, from the flexible components that could be easily changed. And programs, the research and literature shows that programs that are implemented with high fidelity are more likely to have favorable outcomes compared to ones that are more adaptive in a non-controlled way. We also know that adaptations do happen, and they can be intentional or unintentional modifications made to an intervention. And this can include addition or deletion of certain components of the intervention, modifications of the nature of the intervention, how it's being delivered. There can be some contextual changes, and they are usually done to improve the fit between the program and the new setting when it's being implemented. While we often not track them, adaptations commonly occur, and they are very often inevitable because we want to make sure that the current context is taken into account And so this is basically the background definition of fidelity and adaptation. Now, the historical view of these two concepts of fidelity and adaptation, many of you would agree, especially in the RCT field, was that fidelity is the good guy, and adaptation or modification to a protocol, any sort of, is the enemy that we should fight off at any price. We can also think about these two concepts, and they are often thought about as a tug of war of one side being fidelity and the other side adaptation. And if we think about the research concepts that are underlying these two ideas, and I see that internal validity escaped from the screen, but on the side of fidelity, there is internal validity. Higher fidelity will lead to stronger internal validity in a program, and so research designs are often geared toward creating a strong internal validity. On the other side, we want to make programs generalizable, and so external validity is kind of paired up with adaptation as they work together to make the program more appropriate for a given setting or multiple settings. But perhaps a mature way of thinking about fidelity and adaptation is to think about them as both as good guys, and they are together fighting for a successful program implementation. And so the balance of the two and the work of the two together is essential to successful program implementation, especially with complex behavioral interventions. And so you don't necessarily want to think about them anymore as opposites, but necessarily complementary ingredients of an implementation process where you need high fidelity of the core components, and then the flexible components need to be adapted appropriately to the given context. And I will be talking about ways that this can be achieved. So as I mentioned, adaptations commonly occur and they are inevitable. This is the result from a study that was conducted by a group at Emory looking at 12 community-based intervention programs in rural Georgia. And what they looked at in a retrospective manner was what kind of changes were made to the original protocol of the interventions. And as you can see, they identified a number of adaptation styles, types, and then they classified them as types of adaptations. And they also linked them with reasons for those adaptations. So they were trying to kind of unpack this black box and understand what's going on, what is what we are not tracking really. And so you can see that there is a high frequency of these adaptations across these 12 programs. Most of them were very frequent changes, and they could be changes to the educational materials of this program, they could be changes to the intended audience or the program delivery, and in some cases they added new activities, and which, and I apologize because these slides seem to be a little bit cutting up, which were not cutting up on my screen, but I will try to fill in here. But they might have also deleted core components. And what we also see is that there are different reasons for making these changes. In some cases, certain audience expansion can happen to reach a specific audience that was not included in the original program. You can also narrow the audience to be more focused and reinforce your message. And so it's interesting to see when you know these adaptations happen, why they happened. It was also interesting to read about their work and how they learned that some of the adaptations were intentional and very thought out ahead of time or in the course of the project, and others just happened unintentionally, accidentally. And so I would like to talk a little bit about how we can shift this notion of unintentional, accidental changes versus being more intentional about adaptations. There are a number of factors that influence fidelity, and so those can be classified along the lines of more this Rogers diffusion of innovations groups of implementer characteristics, the intervention characteristics, the organization setting and the community that you are trying to implement in, and then the population. And so the different factors are listed here. Without going into too much detail, you can see that these are very traditional factors that we usually try to track in implementation studies at least. And they are influencing how much fidelity we can achieve. And then you can see they also result in adaptations to the various areas, which will influence implementation effectiveness and the dissemination efforts. The way I would like to approach this, how do we address the tension between fidelity and adaptation, is to take two typical scenarios. Either we are there to implement an existing evidence-based program, and so I wanted to show a couple of guidelines that are out there, how to think about adaptation and fidelity along those lines. And then the other group is developing new interventions with the fidelity and adaptation in mind. And there are a number of guidelines out there how to do that and how to create programs that are have high fidelity, but also are adaptable to the local environment. So starting with the scenario that you are taking an evidence-based program or intervention, there is one approach that is very simplistic. And I think that this is really taking out the complexity of adaptation and fidelity. But I think it's very helpful when you first try to conceptualize it in your project. And it is called this green, yellow, and red light adaptation. And many of you might have seen this. The notion here is that certain changes to a program are usually okay without any worry about compromising the integrity of the program. Others might be okay with some caution, and there are changes that are usually dangerous in the sense of you would like to avoid them because they might compromise the integrity of the original program. And so here are some examples of green type of modifications. You might change the name of a health center or systems. You might change the picture or people or places or quotes in the intervention program. In some cases, you might want to make the wording more appropriate for your audience. You might change the incentive to the participants or add incentives to it. And it could be the timeline change or cultural preferences. So these are changes that usually are not going to compromise the integrity of the program. Here is a set of activities that you might do, again, to improve fit for the local context, but you would start to kind of be considering this as a more major adaptation. You might substitute certain activities, so you decide not to follow all the activities that you had in the program, but include new ones. Also, you might change the curriculum steps and sequence. And then finally, there are some changes that are often problematic, and they might actually result in the change in effectiveness of the program, which could be changing the model or theory that is being used or the topic. You can delete core elements and cause some problem in the effectiveness results. And then you could put in strategies that might take away from the original flow of the program, and that can again influence how effectiveness will play out. So this is one way that you can kind of think about the changes that you are intending to do. Another component when you are taking evidence-based programs and you're adapting them is to think of this continuum of, as the changes become more major, then the fidelity might be lower, and then you want to have a little bit more rigorous evaluation of the end outcomes. And so here you can see a list of adaptations as they are going from less serious adaptations to more major adaptations. So when I started to talk about these, I said that I'm simplistic in here, and I think that the most important message or caveat is that high fidelity and adaptation can happen in one scenario together, and they are not necessarily opposites. And so in the next set of kind of guidelines, I would like to present a few ways that you can create a high fidelity implementation program with adaptations to the local context. And these changes are usually recommended at the level of development of the program. So now you are thinking about, when I'm creating a new program, what can I do to create a program that will be flexible in future environments, and I will be able to easily implement it in various settings and with various stakeholders. One of the concepts that I think most of you have heard about is the designing for dissemination and implementation. And so this idea refers to the set of processes that you create to plan ahead and think about your program as something that will be in the future disseminated and implemented. And usually these are strategic steps that are happening early in the development and planning stage of the program development, and they will result in more sustained use. These can include a number of things, including the early stage conceptualization of the model that you are using, active and systematic planned and controlled approaches to the development of the program. We talked about iterative development of interventions, thinking about creating a certain draft and then sharing it with the stakeholders and returning to your program and recreating it. And then also the understanding of the needs of your stakeholders and engaging them early on and throughout the process. there are three sets of guidelines that I found somewhat helpful in the literature when you are thinking about developing these flexible programs with fidelity and adaptation in mind. And I'm just briefly going to show them to you and then summarize the major common components of these approaches. The first one is the flexible adaptive program development. And here what they suggest is that you take a more broad definition of what fidelity means and what completeness means. And instead of conceptualizing your interventions as a set of standardized procedures or components that are rigid and they have to be as they are, you should think about your interventions more as a set of processes that are linked to a logic model. And so then those are the processes that need to happen and the other components become flexible. They also suggest that interventions should be tested in real-world contexts. They should be tested with the engagement of stakeholders from the start. And finally, one component that we haven't talked about too much yet, but this notion of monitoring fidelity and completeness throughout the life cycle of the project. One of the problems that we have right now is that while fidelity is often tracked in one way or another, we usually know how many sessions people completed from the program. We hardly ever systematically track adaptations. And one reason for that is that it was not a focus of our attention and we didn't think that we need to know about them. The other that review panels are not necessarily happy about seeing adaptations being tracked systematically. It can raise a red flag. It can indicate that you are intending to make changes to the program, that you are allowing for changes in the program. And so I think the message here is that if you track it, you will know it and you will be able to account for it. And so finding a way to include continuous monitoring of completeness is essential for us to understand what kind of changes were made, understand why they were made, and how that will impact internal validity, external validity, but also future implementation. The second concept is the empowerment implementation. And those of you coming from a behavior science background are, I'm sure, familiar with the empowerment evaluation, which is very closely linked with the community-based participatory research and capacity building approach. Empowerment implementation suggests that we have to provide tools and skills to the community who will be using the intervention to identify the core components of the intervention and then to adapt that intervention to their context, assess, monitor, and maintain the implementation quality. And they provide a set of steps to achieve this. So again, highlighting the importance of documentation skills, early engagement of stakeholders in a meaningful way. And then the third one, which I will really just briefly touch on, is this 12-step approach. And really the heart of it is to, initially, you want to start with identifying or defining your own fidelity adaptation balance. And that's your starting point for the development of your intervention. And from then, you again use stakeholders and logic models and other methods to create a program that will be flexible. So summarizing from these previous three guidelines and then also from the designing for dissemination and implementation literature, here are 5 take-home messages, I guess. The first one is, it is important that we identify our core components and flexible components of our interventions. And I'm almost sure that one of you will ask, how do you do that? And I will perhaps throw it back to you and say, well, there are some ways, but I don't know if there is a really great way to do this. If you link your program to theories and frameworks and logic models and you know why you are doing steps, that can really help with identifying the core components. There is also a method of core component analysis, which is usually done retrospectively by measuring intentionally the role of each component, but then identifying how those different components play a role in the actual outcome. So those are just some different ways, but this is one of the critical steps. The second one is you want to choose designs that will help you balance the internal and external validity. This can be potentially deviating from the traditional RCT design. It could be choosing settings that are real-world settings or working with populations that are more representative of the actual users or end users of the intervention. I think the most that I have said so far was the early and ongoing stakeholder engagement. And I think this is what links in most with the PCORI kind of need. That even though PCORI is not talking explicitly about adaptations and fidelity, They are very big on the real-world relevance and also the stakeholder engagement piece. And that will feed into this notion of adaptation and fidelity. We talked a little bit about the measuring and tracking fidelity, which I think is being done, but then adaptation, more systematically, more intentionally. And then ideally, we want to make most of our adaptations happen in an intentional manner rather than accidentally. And I think we will admit that there will always be adaptations that we cannot foresee. And so that's why we want to document, go back to point 4. But there has to be a direction or a move toward being intentional about adaptations and understanding that they need to be planned for and created by the stakeholders and the implementers together. So as I mentioned, I will talk a little bit about the existing tools that are out there currently for you to use in your own studies to conceptualize and measure fidelity. The first set of ideas I wanted to share about the different strategies that you can use to collect data about adaptation and fidelity. And they are just traditional. Most of you have used these in your own studies. These are traditional qualitative approaches. Observational techniques, you might be actually direct observe how the implementation is happening, or you might video record or audio record sessions and then check what actually is being delivered. There are focused interviews that are being used, questionnaires, checklists, and logs that could be implemented. Very often, retrospectively, we use content analysis of key documents and curricula. And then study databases or clinical databases. The EMR can be a source of information about what has been implemented and not, and what has been changed. So there are a couple of caveats here. One being, usually you need to use multiple techniques of these. So you cannot just use one. You have to triangulate the data and to understand what really happened. The second one, I don't know that we have a really great way of doing this prospectively at this point, especially the adaptation piece, of really real-time following what's being changed. And when I'm thinking about this, and actually this is something that with the credit program we are trying to do now, to prospectively follow and identify any change that's happening and immediately kind of record it. I'm thinking about the burden on the people who are already tracking a lot of information for us. And so I don't know how to get around that yet, but I think that that's one question. Can we do this well prospectively? And what would be some good ways to do that? And then I mentioned the using of multiple databases. So I think those were the 2 points I wanted to make here. In terms of quantifying fidelity and adaptation, actual numbers, we have some amazing skills developed for usually mental health and school educational kind of programs. They are generally skills that were developed for a very specific program. This is an example for fairly recent mental health skills that were developed. They are usually being tested for psychometric properties. They are linked very closely with the validity and reliability with the given program. The difficulty of these skills are that they are merely focusing on fidelity or exclusively. They are usually very lengthy instruments. They have very strong psychometric properties, but they are also very lengthy. So pragmatically, they are not easy to use. And again, as I mentioned, they are usually extremely specific to the given program. So you couldn't take this instrument and use it across various topic areas or programs, which makes it harder for us to compare results across studies and start to understand what adaptations might happen across programs and how they influence outcomes. So in terms of quantitative measures for adaptation, I don't know of any. For fidelity, there are many. They are not very pragmatically helpful. The way that adaptation is being tracked is, again, not very systematic at this point, if it happens at all. This is one framework that was developed by VA-affiliated colleagues, Sturman and colleagues, the Sturman Adaptation and Modification Framework. And as you can see, what they were trying to do, and it was based on a systematic review of the literature, is to create some sort of structure around what are you looking for when you are documenting adaptations and modifications. And so you can see that it is touching on who made the modification, what kind of components were modified, what level of the delivery this happened, and in what context, and finally, what was the nature of the modification. And they provide some examples for each of these areas. Again, caveat, this seems to be a pretty extensive tracking sheet if you think about it in a study working prospectively. So I don't know how it would work prospectively, and this is what we are running into right now, because this is the framework we propose to use in the query program. So we are now thinking, what are we going to do in terms of pragmatically, how are we going to collect the data that we need to answer these questions. I also talked with Russ actually before this presentation, because I knew that he used the Sturman framework in a retrospective manner with a Robert Wood Johnson funded project of looking at modifications and adaptations in various primary care programs. And his take on this was that there was a little bit of overlap in the terms of the nature of the different modifications that they were trying to classify them. Again, they were using it retrospectively, and so he didn't see how prospectively this will be operationalized. And they also linked it with the REAM framework, which I think is an excellent point, that you want to understand what was the reason for that change. And so the REAM framework might provide a nice selection of did they intend to maximize reach, adoption, effectiveness, implementation, maintenance. And so that could be a nice compilation of the two frameworks to track information. The question still is the prospective approach. And so this flowchart is kind of answering this question of how do we do this prospectively. Again, not ideal, but this is taking on the complexity theory and using a flowchart kind of decision tree approach to decide on what components of the program should be changed as we are implementing it. This is called a TEC tool, and it's called Tool for Evaluating Research Implementation Challenges. And again, based on the complexity theory, our colleagues at the VA in Los Angeles will be using this for their study as they are deciding which components of the interventions are being changed across different sites. And so one example would be to go through this flowchart and realize that a program that initially suggested that you use a 30-minute group session is not feasible in a given setting, but they are able to do a 15-minute one-on-one component. And so this is the type of intervention, change, or adaptation that they might decide on and then document it in a prospective manner. And then finally, in terms of models, the ADAPT-IT model is one of the more commonly used models to think about adaptation, and it just reiterates the notion of stakeholder engagement, various stakeholders, and then the iterative nature of program development. As you can see, they talk about early engagement of the stakeholders with various kind of approaches, using that input to create different drafts of the program, and then revising those based on additional input. And I think that that's another tool that you can tap into as you are thinking about prospective adaptation. So implementation toolkits, this is just seems to be completely out of place, but this is a topic I wanted to definitely mention, because I feel like this could be, again, we are cutting out the bottom piece here, but implementation toolkits can be a great way to create guidance for future implementers about the core components and flexible components of an intervention and help them implement it in the future. You can also use existing implementation toolkits. This is one that is related to practice facilitation. Our colleagues at the Department of Family Medicine develop these programs. But there are other ARC and Cancer Control Planet and other types of implementation guides that you can use to implement interventions that are evidence-based. And they usually have the information about which components you should be keeping and which you should be discarding or changing or can be changed. And this can be topped off with technical assistance and training. So this is kind of a way of reporting and creating information about your intervention. And finally, as we go full circle from creating programs, implementing them, and creating implementation guides, we get to reporting. And so one way of reporting about adaptations and modifications is by being very thoughtful about the information that we include in publications. And I don't know how many of you are familiar with the TIDER guidelines, which are kind of expansions of CONCERT and SPIRIT guidelines, certain components of those. They have 12 items. This particular TIDER guideline has 12 components. And each of those I felt had something to do with adaptation and fidelity. They encourage you to report very clearly about which components are in the intervention, which were actually implemented. And then the specific 8 through 12 are calling out the notions of adaptations, modifications, and fidelity. And they also provide great examples from various types of studies. I just provided a couple here or one, but when you go into the actual publication, they have topics from clinical field, more public health oriented areas. I found this extremely helpful, whether you use it to create your implementation guide or whether you publish your work. So future directions. I wanted to share some existing opportunities for those of you who are interested in focusing in on adaptation and fidelity. But I also wanted to raise some research questions for the field and then ask for your input. So one of the newer efforts is through the VA. It's a cross-query work group that we created to focus on fidelity, adaptation, and tailoring. And we had a couple of meetings so far, looking forward to working with this group. The new query program actually, most of the programs included some notion of adaptations and fidelity in their measurement plans. So what we are trying to do now is look at what the different instruments people will be using. That's how I learned about the tech tool. That's how we share the Sturman model with the other programs. And we are trying to also see whether we could use at least a few items that could be implemented across query programs. So we measure some consistent ways of thinking of adaptations and modifications and draw some conclusions. So that's in progress, and it is focusing on query work, and I think most of our members are actually query program PIs or project managers, but I do know of at least one person who's outside of the VA. And so if any of you have very strong interest in doing work around fidelity and adaptation and would like to join in, I'm sure that we can make that happen. So please send me an email. PCORI was the focus of this series, so I just wanted to circle back, although I feel like throughout this presentation I kept saying stakeholder engagement, so I don't know if I can say anything new. But when I think about, I just returned from DC and had a chance to, this was my very first time to serve on the PCORI review board in their more mature kind of review process. It was on the pilot review on the very first one. But this more mature process, and the emphasis, and truly this was mentioned at least 5 times throughout the review of the 4 grants that we had to review, which was really a light load, was focus on real world applicability of the project, the stakeholder engagement, the patient relevance of the project and stakeholder relevance of the project, and the measures that are affiliated with that. And I think that adaptation and fidelity, as we talked about here, clearly links into this, and there is no way around without tracking those. And there were questions asked during the review about the projects, how they are going to handle the various settings and how they are going to make this scalable, and how they will create evidence that will inform scalability. And so something that, although I didn't see anything explicitly on their website, any of the research calls or priority topics, nothing mentioned fidelity and adaptation specifically, but I think it's throughout an overarching focus of PCORI. And then if you think about the NIH DNI RFA, they actually have specific topic area highlighted for the study of adaptation and fidelity as a special interest. Studies on the fidelity of adaptation of implementation efforts, including the identification of components of implementation that will enable fidelity to be assessed meaningfully. So if you are interested in this area, actually this is a topic area that they are seeking out proposals for. And then finally, again, questions for future work. And I stopped at 3 because these are the 3 things that came up to me in the past year or so as I have been trying to kind of think about how we can include adaptation and fidelity into our own work. One is that I don't think there is a good inventory or systematic review of existing instruments or models that help us really look at fidelity and adaptation measures. For fidelity, you have very topic area specific kind of small publications, but nothing really systematic. So this is something we are looking at with the work group. It will be an enormous work. And so I think that we would like to look into it and see whether there's any efficient way to do this. Perhaps not systematic in the way of traditional systematic, but some focused or planned way. the other piece is, I think we want to start to understand the different patterns of adaptations across settings, program types, and topic areas. And unless we routinely document adaptations and fidelity, but especially adaptation, it's going to be hard to do that. So again, it would be great to include adaptation measures into all of your studies. So we start to build the evidence base to understand what's really going on across studies. And then I don't know that we have a good sense of what is the appropriate balance. I talked a lot about, we need to have a good balance between fidelity and adaptation. What is that balance? And while this sounds like a complex issue, and perhaps it's not one number, but it's starting to kind of get a sense of how do we define the ideal balance would be great. And again, until we start to measure these and link them with outcomes, it will be hard to do that. So I'm sure you have a lot of questions in this area. And so I will go to the end of the presentation, but we'll come back here and ask you what are some hot topics for you in this area. If you are interested in reading a little bit more, I have provided some kind of high overarching publications in this field. There are others. These are the ones that I found most helpful as I was thinking through this topic, and they are giving you a good kind of summary and some examples. And then finally, this is a long quote. You usually don't put something like this into an oral presentation, but I thought that this was really a good summary and a very nice metaphor of what we talked about. And so let me just read this with my really broken English and read it on the slide to really understand it, because I think it truly summarizes all the different concepts that we discussed. So implementing a program is like constructing a building. An architect draws upon general engineering principles, theory, to design a building that will serve the purposes for which it is designed. However, the specific building that results is strongly influenced by parameters of the building site, such as the lot size, the nature of the site's geological features, the composition of the soil, the incline of the surface, the stability and extremes of climate, zoning regulations, and cost of labor and materials. The architect must combine architectural principles with site parameters to design a specific building for a specific purpose on a specific site. This dynamic is mirrored in the rough and tumble world of the human services. Despite excellent plans and experience, ongoing redesign and adjustment may be necessary. And so with that, I will just complete the presentation, and we have plenty of time to talk with each other, so that's great. Let me go back to that future work questions, and thank you for your attention.
I'm working with Russ on this study, and so, the idea of adaptations, I think I liked your, bad guy, good guy, because it's like the idea is, well, that's going to be bad, but it seems like sometimes adaptations could make the program better. And one of the ways we've been thinking about it is, what are the characteristics of people who are good adapters? Like, they make adaptations that actually result in better outcomes. Like, is it something particular to those people that are involved? Like, they know how to take what's core and make it really work in their setting, whereas maybe other people don't do that well. Did you run across any literature looking at it that way, or no?
The only piece that seems to resonate with it a little bit is when you look at these influencers of Fidelity, and they kind of mention the audience. I don't know if I will. Yeah. So the organizational setting and community and the change agents. And so I don't know that any of these studies really focused on, are the people different? They did identify change agents and champions being important in the success. But I really liked, it's kind of a little bit turned around, right? I mean, it's instead of thinking about what components of the programs are being adapted as the important feature or variable, you are saying it's the people who are doing it. It's not really what is being changed.
Well, so we've been studying to what extent patient-centered medical home components get implemented and we picked out a couple of key things. And it's really interesting, like in certain kinds of settings, they do certain kinds of things, and other kinds of settings, they do other kinds of things to make it work, because they both encounter barriers along the way in trying to accomplish that. So I guess I'm kind of thinking it's more like a process or steps, but those process or steps are different in different organizations, and they kind of figure that out on their own, and good adapters figure out what it is they need to do to get to where they need to go in their setting. It might be a different process in one kind of setting than another setting. I don't know. We're looking at a little bit different than like the diabetes prevention program with X number of sessions, and it's a program, and you know, so we're kind of thinking about it a little bit differently. But I still think, like, what are the characteristics that actually get people to success? You know, and it's not just the people, but it's like the characteristics. It's all the stuff. What actually helps them actually implement too. Because that's the first thing in Fidelity, is actually being able to do something. Because, like, if you can't even do it, then your fidelity is really low.
Yes. Yeah, and I think that one is definitely aligned with work that Ross Brunson did with looking at public health agencies and what defined whether they implemented the evidence-based guidelines or not. And so those all came into play there as well. So I think it's not that different from that. But I did like your idea that you have to have a certain, I don't know, skill set, personality of people to do it the right way. The content matters.
Or setting, maybe.
Or setting in general.
Yeah. We're not done yet.
I think there might be, so this fits very nicely with what you're drawing to into the diffusion theory, right? And so you have early innovators, just like you're looking for innovators to adapt. Right? There are, I mean, in that line of work, there's the ways you can profile and identify those folks. So this is used a lot in product development, like, you know, you might have a SaaS user group, or you might have other kinds of software user groups in which people are adapting software to their needs, right? There's other kinds of product user groups, and what companies do is they cultivate that in a way and collect it so that they are using that as part of their market surveillance to say, where are those early innovator adapters? How do you take that now and see and spread it, right? So it's not just kind of like, isn't it interesting to study, but it's like they identify those so that they can spread across those innovations. And they use that as part of their innovation cycle. It's looking for adapters.
Part of that is knowing what they need up front too, you know? Like, versus if you don't know anything and they say, here's what you need. You know, versus like, I know what I need and I'm going to take what is part of something and use those parts and then adapt the other parts so that it works.
No, you're right. I mean, certain profiles, there are people that are usually those innovators are able to take risks easier. They can take evidence and manipulate it to what they are going after. You know, so there's maybe other literature that would help with how you think about profiling.
Related to Borsika's point about designing for dissemination, it would be interesting to see if programs that, I don't know if you could do a comparative effectiveness study, but programs that do this, if they're designing for dissemination during the planning process, and if they considered it, if that actually resulted then in less need for adaptation later on when things go out.
You would wonder whether it's going to be, because that's a very good question in my opinion, whether it results in less adaptation or whether it results in a more flexible program that can be adapted heavily the right way. Because that's the other piece that they were talking about, that once you don't stick with these rigid components but rather processes, it makes it so much easier to implement.
I definitely want to very specific ones, but for me it seems like a very key component that doesn't get addressed a lot is, and that goes along with the, you know, the key people in the group, but like a group that is well managed, which means that there's somebody that's responsible and accountable for making sure that everything within the organization is working from whatever the input is at the very base level to being able to address deliverables at the top level. If that's managed well, it's a completely different, I guess, a completely different outcome than and then going into an organization that's not, and there's not buy-in, so it's skew all of your data that you're getting, and there's power dynamics going on, personalities, organizational structures that are obstructing being able
Yes.
to be objectives and being efficient.
Yeah, no, I think that that's an important point. And obviously there is all that organizational literature, organizational change literature out there that's trying to get to the readiness and the different dynamics and climate. And those are all very important here in the implementation stage. So that's, I think it's an excellent point.
A question from the online participants. She's asking, I wonder if Borsika has comments about GN Century's Fidelity implementation model, which outlines 4 domains that can be described in developing an approach to fidelity monitoring for a specific intervention.
I don't know if I'm familiar with that model. What is it?
She's saying GN Century's Fidelity of Implementation model.
That's a person's name, GM.
Yeah.
I have not used this model, and I will open this up to the audience if you have used it or heard about it. I do know that, again, I presented a few here, but there are a number of adaptation models that can be used, and I don't know if it's very step-by-step or more kind of theoretical, so unfortunately I cannot comment on it. But thank you for letting us know about it. So that's a start of the snowball sampling for the review of models. Anyone in the audience that had any work, specific work with tracking adaptations or even fidelity, thinking about it in their work, or any challenges because they didn't document it that you would like to share?
I can comment on that from in retrospect. In one of our projects that we're working on now. I think one of the problems, as you mentioned earlier, is that we maybe weren't clear enough on the link between the various elements of or components of our intervention are related to the overarching framework. And so we came up with a whole bunch of different pieces that didn't necessarily define them to the practices in a way that was consistent with the overarching framework.
Okay.
We knew in our heads,
Yes.
but we didn't, as you said at the very beginning, on the language. And I think without being able to clarify, here's our framework, here are the components that go along with it, here's the language, that it's very difficult to track that, it's very difficult to engage your stakeholders in those conversations. So creating your framework all throughout, all elements of how you determine how a given program will be implemented. In retrospect, we should have done a better job with that.
Okay.
I don't know how we would have done a better job with
Yes.
that, but that's a problem that I've seen.
I think that's really hitting the nail on the head with some of the things that I encounter, because it's not like a lot of what I encounter in terms of research is how organizations are doing what they're doing. And it's not necessarily that I, as the researcher, inventing something and saying, you need to do these core components and here's our theory and all that, is they're doing things and they're implementing things. Patient-centered medical home, I've been studying care management lately, you know, and they're doing whatever they're doing. And I think a lot of the issue is they don't really have set goals to begin with. They're like, oh, we need to kind of disease manage better, and we've heard that if you get a person to kind of do something with that, then that would be good. You know, and it's not like they're setting out with knowing really clearly what they're doing, why they're doing it, what's core, what's not. And then so it's really hard to sort out looking at us, because we're encountering this in the studies, like, what's an adaptation and what is it we just didn't know, we're figuring out as we go along kind of thing. So I think it's a lot clearer when you have a specific program or you're the researcher and you're directing the efforts, but when you're kind of setting what other people are doing as they're implementing kind of out there in the real healthcare world, I don't even know like what the target is exactly.
Yes.
So it's really hard to talk about this.
Well, that's an excellent, I think both are very important points. I always seem to say that we have to carry through the model and do the best, and then in the real world, it's hard to do that because there's sometimes no model. But I think that speaks really to one of the comments we had on this FAT call, this Fidelity, Adaptation, and Tailoring call. This was the person outside from the VA. He is from the Karolinska Institute from Sweden, and he said that, you know, the truth is that this whole thing that you are talking about, and you're trying to put these definitions and nomenclature and the whole idea, this is not what you should be doing. Because the truth is, we are observing people in Europe. We go out and we see what they are doing, and we let them do what they need to do, and then we, take notes and we measure it, but we are not giving them structures, because that's not how real world works. So I completely appreciate what you said.
Try to sort through that and figure out, well, it seems like that was important, that part,
Yes.
and that part was,
Yes. And he's coming from much more that organic, don't, control the things ahead of time. This is what's happening, let's watch it and let's document it. And so I think that this is really a more of a structured approach to it, and how often are we able to truly carry it through, I don't know.
But I do agree, though, like when you're talking about methods, like we have, the study that I have, we have the care managers report to us like every 3 months on what kinds of changes have happened, and what has been the impact, and trying to keep track of what's
Yes.
happening and why it's happening, so that you're maybe have some sense.
Yes.
But it's hard to get that kind of data, I think.
I agree.
I was just going to also say that we've had a lot of trouble recently in terms of who you're dealing with in an organization. Who you're partnering with. Like, we were partnering with the high-level people, and we thought with people on the ground. And it wasn't so much about fidelity as it was doing other things that were highly related to what we were doing, and the lack of understanding that, in fact, although we were trying to increase immunization rates, they were trying to increase child care rates. And even though those entirely confound one another, but it's just so hard sometimes when you're, these people were involved in weekly calls with us. They were our partners, and yet they did not see that something else they were going rogue on was completely messing up what we were doing. It's really very difficult. Anyway, that's it. It sort of goes to how you measure fidelity. I mean, you may be measuring fidelity of an intervention, but something else is going on that's entirely related.
Yes.
To what what you're trying to measure.
You're changing the context in which your programs, your intervention has been implemented.
And I don't know if I have
No, I mean, it's just a live and learn. But,
Yeah.
Keeping your finger on the pulse of what is going on within your intervention is one thing, but then within the world of interventions that are going on in the practice, it's really hard. And, you set up systems to do that, but systems fail. Anyway, very difficult thing.
Yeah, it is very messy. Elaine, did you?
I would just underscore related to that is, I guess what they're saying is the value of directly observing in the context itself, right? Because people often don't realize the context themselves, right? That's just where they are, and it's only by directly observing see what's coming. And I think what you're doing, Jenny, is so valuable in the care management, because you're combining what you're observing with what you're collecting, so you're triangulating that information for a better picture, because a lot of people don't realize they've made a change for a reason, which is doing takes someone else. So they might not even articulate they made a change, right? You have to observe it.
Yeah, I think that just a moment, just to reflect on that. One thing that came up to us actually in the query program was the journaling idea, and we actually just discussed it. I don't know how well this can be implemented on a daily basis, but this notion that you want to have a journal like in the old lab world when you wrote down everything and do it in a regular basis and journal about what you're experiencing, because changes are happening on a daily basis. Who will remember at the end of the study to even write it up or document? And so there are some templates and there is a guidance of how to journal. And so if someone is interested, I'm happy to send over those. But yeah, it's tricky to keep very close attention on the issue and then know what's happening around it. And perhaps journaling is a good way to reflect, I guess.
I was just going to talk a little shout out to data collection also, and how the how it's being done, with how, especially at the very first point of contact, is very important. Even with observation, right? Observing, there's kind of having understanding or being aware of power dynamics. I've been in groups where we're doing focus groups with somebody's boss in the room, and as far as I'm concerned, that's yeah. But it's hard to address that with just through power dynamics within an organization or within any organization.
I think that that's an important point, and I don't know if any of you have experience collecting data on adaptation. We heard one idea of calling them and regularly checking in every 3 months, but are there like ways that you have done it and it seemed like better than other ways?
I've seen an example where you go through and you just, you're not necessarily calling a meeting.
Yeah.
But it's that ethnographic, anthropologic kind of site evaluation, right? So you kind of the patient flow or whatever the flow dynamic you're trying to sort of, and you're kind of, you don't want to be seen, right? And you're just able to see the natural state like an anthropologist, right? So I've seen those methods work well.
Yep.
And I'll give an example that's not healthcare, but I think illustrates it. So we used to do this a lot in consumer product development. People would talk about how they do their laundry, right? And you say, oh, doing my laundry is super easy. That's what they would tell you, right? When you actually observe them do their laundry, but they would fill up their laundry thing, then they would put in the detergent, then they would stir it, and then they would close, right? They would say that was easy. They had adapted, so they found a way that worked for them to get the granules to salt, etc. The insight was observing that and saying, well, really, it's not easy. If we could do a product that was doing that already for them, that would be what they would want. Like, you couldn't have gotten that knowledge without actually being there, watching them do their work every day, because they thought it was easy. Yeah, and that would have been what they would have shared and they would try to do actually.
So one thing that worked pretty well for us in terms of what we did is we usually thought through the data collection, all of this so then we had budgets, plans, PCB, kind of going up, and it happened in all those plans. Basically, we had to use them that we had in place because it kind of helped us collect the data that we needed and wanted instead of having, we had 8 or 9 or 10 different data collectors who not through the same way.
Yeah. No, I think that's an important point of the intentionality of, whether it's the adaptations or how we collect the data to have those plans and anticipate what's going to happen. I think we are right on the top of the hour. Yeah. So thank you so much for your attention and thank you for the opportunity.
Yes.